Ready? Yep. All right. Good afternoon, everyone. Welcome to today's Endocrine Grand Rounds. It's a pleasure to be here and to introduce Dr. Catalina Cabrera. Dr. Cabrera completed her training in pediatrics and endocrinology at Cincinnati Children's. She joined our practice at the University of Louisville and Norton Children's in 2018 as an assistant professor in pediatric endocrinology. And over these last 5 years, she has been an educational and clinical leader for us. She has led our high-risk diabetes program, our DART clinic, as well as initiating our first genetic growth disorders program that includes Turner syndrome. And so very appropriate today that she'll be speaking to us about one of her passions, and it's growth hormone insensitivity syndrome. So please welcome Dr. Cabrera.
All righty. Well, thank you, Dr. Wintergers, for that nice introduction. So yeah, I'm very passionate about, I feel like growth disorders in general. So I know that for our adult colleagues, this might be not as relevant as peds, but you know, you'll get to learn some of the rare aspects, I would say, of the growth hormone IGF-1 axis today. And for our fellows, so this is, I think, very ideal for boards. So take note here. All righty. Okay, so I don't have any disclosures. Okay, so today I'm going to start with a brief case of a patient with one of these growth hormone sensitivity syndromes. Then from there, we'll move to the definition of growth hormone sensitivity syndromes as a group. We'll talk about some of the background and physiology of these conditions, a little bit of history, and then I'll finish just trying to talk about the highlights of like these syndromes and, you know, cover hopefully all of them, or at least the ones that we know so far that exist. So our case, so we had these two siblings that presented to pediatric endocrinology for evaluation of short stature. The first patient was a 13-year-old boy. Height was, had like mild to moderate short stature. He was a minus 3.2 standard deviations, and then his brother was 10, so a little younger, and his height was similar, around minus 2.8 standard deviations. Here we have the pedigree, so we can see that the parents are actually first-degree cousins. So I think that should always like be a red flag to like think outside of the box. And this is their growth chart, so we can see both of them are on the short side. I wouldn't say that they have severe short stature, but definitely it's on the moderate category. And here with the red arrow, we see their mid-parental height. So their parents are maybe just a little below average, but they do not have significant short stature. So patient one had a normal physical exam, was non-dysmorphic, was in early puberty, bone age was normal as well. Growth factors were very low, so IGF-1 and IGF-B3 were very low. Similarly, his brother had a normal physical exam. He was pre-pubertal, bone age was a couple of years delayed. Here again, IGF-1 and IGF-B3 were low. So initially, like they were concerned about growth hormone deficiency with the low growth factors. They actually did a growth hormone stimulation test on both boys. And interestingly, they found that they had a really robust growth hormone response. So on patient one, it was 61. On patient two, it was 38 for adult friends that are not very used to like doing these growth hormone stimulation tests very often. So our cutoff that we use here normal is 10. And I would say like most of the patients that we see are usually like in the 10s to 20s, but like definitely a level of like 40, 60 is really high and not what we typically see. So going back to the pedigree, so again, parents were first-degree cousins, so they suspected that maybe there was something genetic going on. They went ahead and did some genetic testing, and then they found that they had a homozygous mutation. They had the missense P73L mutation in the EGFALS gene that encodes for the ALS gene. So ALS is the acid labile subunit. So they did ALS levels in these patients. They were undetectable, and the kids were diagnosed with ALS deficiency. So I will, refer back to this case, because I'm going to try to cover all of these different syndromes, and then we will talk about ALS deficiency as well. All right, so in general, growth hormone insensitivity is a group of inherited conditions where we have a reduction or absence of the biologic effects of growth hormone, despite having above normal secretion of growth hormone. So typically, all these patients that have these different conditions have growth failure, and they have normal or increased circulating levels of growth hormone. So this was first described in 1966. Typically, it has been classically associated with monogenic defects in the growth hormone receptor. And that's kind of like what we knew back in 1966, and that we know causes Laron syndrome and will result in severe postnatal growth failure due to lack of IGF-1. But now here more recently, we have recognized multiple other monogenic defects that are downstream of the growth hormone receptor that obviously has expanded our understanding of other causes of growth hormone insensitivity. So I think that I have shown this slide before, but I think it's nice to review the physiology of the growth hormone IGF-1 axis. So we know GnRH is secreted from the hypothalamus, and that stimulates the anterior pituitary gland to make growth hormone. Growth hormone is released, and it binds that growth hormone receptor. Then growth hormone activation actually requires the recruitment of JAK2 and the phosphorylation of STAT5B for transcriptional regulation of IGF-1. Then IGF-1 is mainly produced in the liver, as well as some of the binding proteins, mainly IGF-BP3 and IGF-BP5, as well as ALS. That is the one that we were talking about in the initial case that I presented. So IGF-1 circulates as this ternary complex that basically just prolongs the half-life of IGF-1. And then we have PAPA2, that is a metalloproteinase that will cleave that ternary complex and will release free IGF-1 into the circulation. And that free IGF-1 is actually what binds that growth hormone receptor. And then we have some complicated transcriptional regulation finally will promote growth. So I will keep referring back to this figure throughout my presentation as I talk about all the different conditions. So basically all the places where I have the little golden star is the places where we can have defects that will cause growth hormone insensitivity syndromes. So we're going to start here with the growth hormone receptor. All right, and then we'll move here downstream until we finish at the IGF-1 receptor. All right, so we can divide, I don't know why the box is looking like that, but well. So we can divide these conditions in 3 different groups. So mutations in the growth hormone receptor, in STAT5B, and in IGF-1 will actually disrupt the production of IGF-1 itself. So with all these conditions, we'll have really low levels of IGF-1. Now, mutations in ALS and in PAPA2 will actually disrupt the transport and the release of that IGF-1, which ultimately will be free IGF-1. And lastly, if we have defects in the IGF-1 receptor, that will actually disrupt the functions and different actions of the IGF-1 molecule. All right, so I will talk here really quick about the growth hormone receptor. So the growth hormone receptor is a type 1 cytokine receptor. It is located on the short arm of chromosome 5, and 9 out of the 13 exons encode for the actual receptor. So here we can see that it has an extracellular domain. It has a transmembrane domain, and then it has an intracellular domain. And then growth hormone binding protein is actually cleaved, is produced by cleavage of that extracellular domain. So once the ligand or growth hormone binds the receptor, that extracellular domain will just be cleaved, and it will convert in the growth hormone binding protein. All right, so I will talk here a little bit about the history. So as I mentioned earlier, growth hormone insensitivity was initially reported in 1966 by Dr. Laron and his colleagues. So he reported the case of these 3 siblings that had hypoglycemia They had other clinical and laboratory signs of growth hormone deficiency, but they had really high concentrations of growth hormone. And here we can see on the right, there is a picture of that initial report, and here is one of the patients with Lerone syndrome. This patient, I think, was like 3 years old at that time. And now here more recently, we have uncovered additional molecular defects that classification of growth hormone sensitivity has really changed over time. So you guys see it? Well, maybe not very well, but I'll walk you through it. Okay, so this is the initial classification that was proposed back in 1996. So all the things that are in bold italic are actually theoretical at that time. So they thought they existed, and we theoretically thought that it was a thing, but we hadn't actually discovered like those molecular defects. So we knew that there was hypothalamic dysfunction that would cause like IGF-1 deficiency, pituitary growth hormone deficiency that would cause IGF-1 deficiency as well. And then there was a third category of growth hormone insensitivity. And then in this category, we already knew about primary growth hormone insensitivity, or Lerone syndrome, because again, that was described back in 1966. And we knew about like all the various mutations that they could have in that extracellular domain, transmembrane or intracellular domain. But then here, everything else was theoretical. So they thought that there was abnormal growth hormone signal and transduction due to defects that were distal to that growth hormone receptor. They thought that there was probably some primary defects of IGF-1 synthesis, primary defects of IGF-1 transport and clearance, and IGF-1 resistance. So this was that initial classification. Now here more recently, in 2014, this new classification was proposed, and now here we knew about like all the other molecular defects that we could have downstream of the receptor as well. And here we have the growth hormone receptor defects as well, and now we knew what actually caused the growth hormone signal transduction defect that was mutations in STAT5B. And then from there, we knew that there were different things that would cause defects of IGF-1, including gene deletions or mutations of the IGF-1 gene. Now transport defects of IGF-1 as well, including the ALS mutations, PAPI2 mutations, and then lastly, IGF-1 receptor defects. And then there was a last category of a bioinactive growth hormone molecule, and these patients typically are treated with growth hormone. Right, so now I will start talking about like each of these defects, again, going back to our growth hormone receptor. So classical growth hormone insensitivity, or Lerone syndrome, is a rare autosomal recessive condition that is caused by exon deletions or mutations in the growth hormone receptor gene. This is rare, but it's actually the most common of all of these very rare conditions. So most of these mutations, again, as I mentioned, are actually in that extracellular domain that, if we remember, is also the growth hormone binding protein. So often, about like 70 or 80% of the patients that have Lerone syndrome will have a mutation in that extracellular domain. And for that reason, they tend to have low levels of growth hormone binding protein. So there are about 70 mutations that have been identified. The most common is mutation in the growth hormone receptor gene. It's the E180 splice mutation in exon 6. There are worldwide about like 400 patients that are affected by Lerone syndrome, and then there are two large groups that have been investigated by a different group of researchers. So there is a group of probably more, at this point, I guess it's more than 69 individuals that live in Israel. And this, I think, is where Dr. Lerone initially described the syndrome. And there is another cohort, the Ecuadorian cohort, of like around 100 patients that live in the villages of Loja in southern Ecuador. Here in this picture is Dr. Jaime Guevara. He's actually the physician that like initially discovered this group of patients, and he's actually done a lot of research. And this is a group of patients from Ecuador that has Lerone syndrome. All right, so as far as the molecular aspects of Lerone syndrome, so we know that we have a mutated growth hormone receptor. So for that reason, our growth hormone that is perfectly fine is not able to activate that receptor. And that results in IGF-1 deficiency and then inhibition of like all the signal transduction that occurs like downstream of that receptor. So as a result, again, the receptor is not working. They have low levels of IGF-1. They have reduced feedback inhibition in the pituitary gland, and that causes like really robust secretion of growth hormones. They have really high levels of growth hormone. And again, going back here to the low levels of the growth hormone binding protein, about like 70 or 80% of the patients that have the mutation in the extracellular domain will also have the low levels of growth hormone binding protein. Now, there are multiple mutations that have been described in that transmembrane or intracellular domains, and those patients can have normal or even high levels of the growth hormone binding protein. So it is a clue, but you cannot completely base the diagnosis on that. All right, so as far as clinical presentation, so obviously the most significant is severe short stature. Females typically are between 3'7" to maybe 4'6" on the tallest, and men are a little taller, so they're between like 3'10" and 4'8". Here we have a picture of the same patient as an infant, as a child, and then as an adult. So here we can see how like the obesity progresses as they grow. They have small hands and feet. They have small organs. They have a very specific facial features with like protruding forehead. They have like the saddle nose and kind of like mid-face hypoplasia, like similar to what we see with patients that have like profound growth hormone deficiency. And they have like some hair issues as far as hair, nails, also like some teeth abnormalities. So they have like very crowded and defective teeth and high-pitched voice. And then, as I mentioned, some obesity that progresses with age. Typically in some boys, hypogenitalism is described, and like they can have a microphallus, but most patients actually have like normal puberty and they have normal fertility, and that's why we have like this groups of patients that just live in like this very like regions of the world. Okay, so patients, this is very interesting. I think that patients with Laron syndrome actually have a low cancer risk. So Dr. Guevara, that has been studying these patients, so he's been like looking at morbidity and mortality for like close to 100 patients from Ecuador since like 1988. And there's only one case, I think had like a form of ovarian cancer that died from cancer, compared to like, you know, several relatives of these patients. I mean, he reports like over 1,500 that had mortality from cancer, and the rate was about like 20%. So, and then something very similar that they have found in that cohort from Israel as well. So here, you know, the hypothesis is that we think, well, we know, I think, that that increased cancer risk in general is due to the link between the growth hormone and IGF-1 signaling, and then those main pathways that are involved in the regulation of cell growth. So I guess like they don't grow, but then bad things don't grow either. So they are protected from cancer, and they tend to actually have pretty significant longevity, like they live. As far as treatment, so recombinant human IGF-1 is approved by the FDA for severe IGF-1 deficiency. It improves their growth. So typically in that first year is when we see the best response. So they go from like about 3 centimeters a year to about 7. So it's obviously not as robust as what we see with our patients with growth hormone deficiency, but very significant. And the first year is the best response, and then obviously starts to slow down a little bit from there. So in the second year, slows down to 5 to 6 centimeters. And then from there, it's usually around 4 to 6 centimeters a year during, 3 to 12 years of treatment. And usually once they complete growth, they stop the therapy. Typically, treated patients will gain around 2 standard deviations. So I think it's pretty significant. And the longer they're treated, the better. Now, some of the side effects, I think that overlap with growth hormone as well. The most common is lipohypertrophy. About like 71% of the patients will have that issue. Hypoglycemia is very common as well, and it tends to be more severe in like younger babies and like younger patients, and in smaller patients as well. And then they can have snoring and like tonsillar hypertrophy. They'll have like some hypertrophy of like soft tissues, typically like around the face, but it's interesting that when they're treated, they get like coarse facial features, but it actually tends to like regress once they stop the treatment. All right, so going back to that initial figure, so we talked about our growth hormone receptor, and now we are going to move down to STAT5B. So again, so we know STAT5B is very important because the growth hormone receptor actually relies on that cytosolic JAK2 STAT5B signaling pathway to transduce signals from that circulating growth hormone to the IGF-1 gene. That's very important for growth. Okay, so STAT5B deficiency is very, very rare. This is also an autosomal recessive condition that is caused by loss of function mutations in the STAT5B gene. Most of the cases reported are autosomal recessive, but there are a few dominant negative mutations that have been reported, and typically these patients will have a milder phenotype. So there are around like 14 cases reported in the literature. Here we can see two patients. This one actually has a nasal cannula because one of the features of a STAT5B is that they can have immune deficiency and like severe like lung issues. And here's the growth chart. So very significant short stature that is similar, I think, to Lerone syndrome. So as far as the clinical presentation, severe postnatal growth failure is I think the most important one here that ranges between -3 to -10. I think the mildest one here is for patients that have the dominant negative mutations, and the most severe is for those that have the homozygous mutations. So here on the right, I thought this was a nice graph here comparing STAT5B mutations with growth hormone receptor mutations, and you can see how the recessive cases have the most severe phenotype, and they are significantly shorter. Now here is the dominant negative mutation, dominant negative here, so similar again. And here we have the autosomal recessive, just the carriers, and that have like more normal height. So in addition to the short stature, they have immune deficiency with potential fatal pulmonary involvement. It's not very well understood why they have the immune deficiency, but the thought is that some of the cytokines actually activate STAT5B, and IL-2 is one of the most important ones that they have done a lot of research on, but it's not really fully understand. They have eczema, they have normal intelligence. And then recombinant IGF-1 has been tried in the past, so there are a couple of reports, but it's not very effective. It does not work as well as it does with Lerone syndrome, so it's not typically used just for like growth purposes. Now, unfortunately, because of the lung issues and the immune deficiency, like these patients tend to die early on, like usually like teenage years. As far as the biochemical profile, very similar to Lerone syndrome. They have elevated growth hormone, and then they have severe deficiencies, not only in IGF-1, but also in IGF-BP3 and ALS. One thing that is interesting here is that these patients have elevated prolactin. They think that there is something to do with the negative feedback mechanism, but it's also like not very well understood. Okay, back to our figure. So we have talked about the growth hormone receptor. We talked about STAT5B. And now we are going to move down to the IGF-1 gene. So IGF-1 mutations are extremely rare. I actually have been lucky to see at least one or more patients with like all of these, except for this one. I have never seen like during fellowship, like any patients that had IGF-1 mutations. So this was first described in 1996. There are about like 7 cases that have homozygous IGF-1 mutations that have been reported in the literature. So one thing that is different here from like the ones that we have described so far is that these patients not only have postnatal growth failure, but they also have severe IUGR. So IGF-1 we know is a very important regulator of like intrauterine growth, right? And it's actually independent of growth hormone. So that's why like patients that even if they have like an absent pituitary gland and they have like no IGF-1 in theory, they would still have a normal birth weight because that IGF-1 is secreted from the placenta. But patients with IGF-1 mutations have in utero growth restriction. They have severe short stature here again. They have deafness, microcephaly, and mental retardation. Now, as far as the biochemical profile, we have an elevated growth hormone level. Typically, they'll have low IGF-1, but again, depending on where the mutation is in the gene, they can potentially have normal IGF-1 as well, and the IGF-BP3 level is intact. All right, so now we talked about growth hormone receptors, STAT5B, IGF-1, and now let's talk about ALS deficiency. So going back to that initial case, right? So ALS deficiency was described in 2004. So this one is newer. I mean, I guess because it's been 20 years already. So it was describing a 16-year-old boy that was referred for short stature in the late puberty at that time. Now there are over 60 cases that have been reported from like 31 different families. And these patients have homozygous mutations in the actually, I like misspell it here. IGFALS gene is how we spell. So here we can see how ALS and actually BP3 or BP5 are important to like prolong the half-life of IGF-1. So when we have that ternary complex, the half-life is around like 16 to 24 hours. And we have about like 80 to 90% of the IGF-1 bound to ALS and IGF-BP3. We have a smaller percentage that is that travels in the circulation as a binary complex. The half-life is between 30 to 90 minutes. And then we have free IGF-1 just alone. The half-life is only 10 minutes. So it's not, it doesn't really have a chance before it gets. So as far as the clinical presentation, these patients typically have mild growth retardation. So it's not as severe as like all the other conditions that I have described so far. The height is typically between -2 to -3 standard deviations. They have significant insulin resistance, and it's thought to be like just due to like the high levels of growth hormone and all the counter-regulatory actions of that growth hormone and like other systems. Some boys have pubertal delay, and they do not respond very well to growth hormone IGF-1. So typically these patients are not even treated because the short stature is pretty mild. Like they're non-dysmorphic. I'm pretty sure that there are multiple cases out there that are not even diagnosed. But the biochemical profile is impressive. So like I feel like the clinical picture is very mild compared to what we have in their biochemical profile. They have robust growth hormone levels, and then very, very low levels of all three, IGF-BP3, IGF-1, and ALS. So here we can see like their height. So this is height minus the midparental height of patients that have ALS deficiency. This is wild type, so like patients without ALS deficiency, and these are heterozygous carriers. They're a little below. All right, so now moving on. So we've covered growth hormone receptor, STAT5B, IGF-1, ALS, and now we're going to talk about PAPA2. But before I move to PAPA2, I just want to highlight here that there are actually no cases of mutations in IGF-BP3, IGF-BP5, or actually any of the binding proteins. So like we have wondered like, okay, so there are all of these things like all along the pathway, but nothing with IGF-BP3. So they think that there is significant overlap of function of like all the various like binding proteins. And probably there are many patients that have multiple mutations in like all the different binding proteins, but like the other binding proteins will just do the job. So clinically, like they're fine. They don't have any symptoms, so that's why we don't even know they're somewhere out there. All right, so let's go back to PAPA2. This one is very rare. This is actually the newest one. It was described in 2016. So far, there are 7 patients that have been reported from like 3 unrelated families, and is due to homozygous mutations in PAPA2. The biochemical profile here is very interesting because, again, these patients have really high levels of growth hormone, But because they have, they're not able to like release that free IGF-1 due to the lack of that PAPA2, the total IGF-1 and the total IGF-BP3 is very, very elevated. So like the total amounts are really high, and that's what we measure at the lab. So, you know, we would see a patient with short stature, really high IGF-1, really high IGF-BP3, and, you know, actually really high growth hormone as well. But if we measure the free IGF-1 level, that actually will be low. But this is not something that we measure like commercially, like it's not available at like the regular labs, but they will do it for like research purposes. So as far as the clinical presentation, they have a mild to moderate growth failure. These are like two of the families. These are two patients from Spain, and these are like three siblings from New Jersey, but they're of like Palestinian descent. They have progressive growth failure, so microcephaly. They have normal intelligence. They have like thin, long bones and low bone mineral density, and they also have abnormal glucose metabolism with some insulin resistance. So I think all of these, well, not all of these, but like I think 3 of these patients have actually been treated with IGF-1 deficiencies, and they say that it improves growth and metabolism. Their response, I think, is like modest. So these patients here are not very short, while these, I think, are significantly shorter, but they had very tall parents, and they have like a higher genetic potential. All right, so now I talked about growth hormone receptor STAT5B. We talked about IGF-1, ALS, and now PAPA2. And last but not least, I'm going to talk about the IGF-1 receptor. All right, so mutations in the IGF-1 receptor are also called IGF-1 resistance. This was described in the late 70s. So the first one that was described was Laron syndrome, then this one, and then the other ones, I think it's been more recent, like in the 1990s and 2000s. Typically, these are heterozygous. So like these patients have autosomal dominant mutations in general. And there are very few cases of like homozygous or compound heterozygous that have been reported in the literature, and they have a more severe clinical presentation. So I think here on the right, this little girl in infancy, childhood, and I think adolescence had actually a homozygous IGF-1 mutation, and she was very small and had multiple other issues. So as far as clinical presentation, so again, just like patients that had mutations in IGF-1, they have severe IUGR, and they have also postnatal growth retardation. So typically the height is variable between -2 to like -5 standard deviation. Again, similar to like IGF-1 mutations, they also have microcephaly, and they have intellectual disabilities. They have insulin resistance. Some of the patients, they say about like 50%, will have some dysmorphic features. And some of the things that they describe is that they can have like posteriorly rotated and then low-set ears, small hands, and small fingers, hypermobility, and then broad or like a flat nasal bridge. So here a few years ago, Dr. Wallenkamp, they proposed like a clinical score to basically decide if someone needed to have like molecular testing and just like genetic testing for IGF-1 receptor defects. And if the patient has like 3 or more of these criteria, you know, like sensitivity was actually 76% and specificity was 87%, on like that paper that she wrote, I think that they at least deserve to have some genetic testing for these. And now the criteria are low birth weight, low birth length, below -1 standard deviations, height, well, significant short stature with height at presentation below -2.5 standard deviations, microcephaly with a head circumference at presentation below -2, and then actually an elevated IGF-1 level over 0 standard deviations. So it's interesting that these patients actually have a lot of overlap with another, I would say, a relatively common syndrome that we see, that is Russell-Silver. So patients with Russell-Silver also have, they're also IUGR, they have postnatal growth failure. These kids tend to have a lot of like feeding difficulties that we also see in patients with Russell-Silver. IGF-1 level, I mean, it's totally fine in Russell-Silver, and it can potentially be, you know, like a little above average. But the head circumference is the key to like differentiate, because like those patients with Russell-Silver have like relative microcephaly, while patients with IGF-1 resistance, also patients with IGF-1 mutations, will actually have microcephaly. So as far as treatment, let's talk about the biochemical profile here. So typically they have normal to like mildly elevated growth hormone, normal IGF-BP3, but they have an elevated IGF-1 level. So again, if we have like all the phenotypic features and then we have an elevated IGF-1 level, I think is important to consider testing for IGF-1R mutations. Then the treatment, this is of like all the conditions that I mentioned so far. This is the only group that is typically treated with growth hormone. They have a, I mean, I would say a significant height gain of about like 1 standard deviation. And typically these patients are treated under the SGA with poor catch-up indication. And we just have to like tolerate higher levels of IGF-1. I mean, I think it's relevant to know that that's what they have, just so we know, because otherwise I think that we would not even be able to treat them with growth hormone. But it's okay to tolerate levels up to like +3 standard deviations of the IGF-1 level. All righty, and if you were not paying attention at all during my whole talk, all you need to hear is the next 2 slides, because I have everything like nicely and like summarizing here. So yeah, next 2 slides are the key. So I'll be a little redundant, but so growth hormone receptor defects are autosomal recessive, and they will cause IGF-1 deficiency due to disruption of growth hormone action. They have the typical the biochemical profile with high growth hormone and very low IGF-1, BP3, and ALS. And then one thing that is different here is that most of the patients will have a low growth hormone binding protein. STAT5B is typically autosomal recessive, sometimes dominant negative. They have IGF-1 deficiency due to growth hormone signal transduction defects. They have a very similar profile here to Laronde syndrome, but they have normal growth hormone binding protein, and they have elevated prolactin that I think is unique to STAT5B. And these are the patients that will have the lung involvement. These 2 have very severe, these 3 have very severe short stature. Now, IGF-1 is autosomal recessive, causes disruption of IGF-1 production. Their biochemical profile is similar here, but IGF-BP3 and binding protein are normal. ALS is autosomal recessive, and the mechanism is a transport defect of IGF-1. And here, what is interesting is how discordant is the clinical presentation with the severe like laboratory abnormalities with like very high growth hormone and very low IGF-1, BP3, and ALS. PAPI2 is autosomal recessive and causes disruption of IGF-1 bioavailability. And they have very interesting biochemical profile with really high IGF-1 and IGF-BP3 levels. And then IGF-1 receptor defects are different because these are typically autosomal dominant, causes a disruption of IGF-1 action, and then these patients have very elevated IGF-1 levels. And last but not least, I have a nice algorithm here. I don't know if you can see it well. Yeah, I like modified these. This is one that was that I found from a paper that was published in like 2011, but I changed it a little bit just to like include some of the most recent defects that have been described. So basically, when we have a child with short stature that has potentially some like interesting history, I feel like one of the things that we never ask about consanguinity, like, you know, but I think that we should always think about it because we never ask like, hey, are you related? You know, especially when we have like some red flags on like clinical presentation or labs or But if we have a history of consanguinity, a family history of short stature, and that's mainly for those autosomal dominant conditions that we would see like in every generation. If they have abnormal development, hypoglycemia, if they have low birth weight versus normal birth weight, deafness or immune deficiency. Now, these groups are divided into those that will have low birth weight and those that have normal birth weight. So in the group that has low birth weight, we want to think about microcephaly plus minus dysmorphisms, and then the two conditions that will cause this are IGF-1 mutations and IGF-1 receptor defects. Now, when we have normal birth weight, if we have severe growth failure and they have immune deficiency or lung problems, then we want to think about STAT5B. Now, if they have severe growth failure, but they don't have these issues, but they have certain like phenotypic features, then we want to think more about mutations in the growth hormone receptor. And if they have mild growth failure, and depending on what the biochemical profile is, we want to consider ALS deficiency or mutations in PAPA2. And that's all I have. So I'll be happy to take any questions.
Beautiful slides. Best of our.
Thank you. I can teach you. It's not that hard, I promise.
I didn't know you said maroon dwarfism. They have long longevity. I did not know that. What's their average lifespan?
It varies, but typically normal. I mean, it's pretty normal. They live like all of us, so like 70s, 80s. Yeah.
If they treat IGF-1.
Yeah. That is a good question. I don't know, and I think we don't know because I don't think IGF-1 has been available for very long. So I think those patients that have been treated with IGF-1, are probably still alive, but I think that will be interesting to see. But IGF-1 hasn't been around for as long as Laron syndrome has been, so not that we know so far, I would say. Right. Let me see.
They usually get the IGF-1.
So typically you want to start it very early. So typically they'll start between like 2 and 3, and you want to continue until they're done with growth. Yeah.
Because, I mean, at one time, IGF-1 is treated for hypoglycemia, and deficiency causes resistance. It was tried for diabetes treatment.
IGF-1?
Correct.
It could
They
potentially.
stopped the clinical trials.
Yep.
Because, of course,
Side effects, yeah.
Of the side effects and potential side effects.
Correct.
And one of them is the risk of cancer.
Correct. Wants to take that risk.
For 50 years. So,
Yeah, and I feel like the applications of IGF-1 are also so limited that, like you're right. I mean, like any company wants to like take the work and invest so much to just for a few patients that can be treated.
because there was one interesting side effect, because we were supposed to start the study, but we didn't because the company decided not to do the study. But when they had sent us all this data, there was one thing about it, and I haven't heard much about it, but since it's there in this population, that it causes arrhythmias. Is that
Oh.
something that,
I did not know.
Adults with diabetes, so that's a different population.
That I didn't know.
Those that they were using.
That is very interesting because, I actually participated in one of the trials that they did in Cincinnati to treat these patients with PAPA2. And I read a lot about it, but I don't remember seeing arrhythmias, but we would get EKGs as part of like just a surveillance study.
Or other, phase 1 studies where they actually use IGF-1 to see the response, to study the insulin resistance. That's when they had it, which is different from giving the shot.
Yeah, and I think it's very different to give to someone that is actually deficient, in IGF-1 versus someone that is not. But
so why would they not give IGF-1 for the IGF-1 receptor?
Well, because it doesn't work. I think that you can correct, but I think that you can increase their endogenous like IGF-1 by just giving exogenous, growth hormone. And it's more available actually than doing like Increlex, and you probably would have the same effect. Yeah, but when you give recombinant IGF-1, you're actually giving kind of like the free version of IGF-1 as opposed to like your own endogenous IGF-1 that will be like bound to like the other molecules and has probably, this is just me, this is my theory, I don't know, but it would potentially have like a longer half-life, and I think it would in theory be like more effective than just giving the free version that would have a shorter half-life. And I don't know, that's just my theory.
So in the ALS mutation, they have an increased IGF, and they continue to make more and more IGF, correct?
They
Even
no
though
no no
that
no
was
ALS.
The IGF production rate in the liver.
They make it, but again, it gets degraded in the
Correct.
circulation. Yes, because there's no ALS and there's not enough 53. You know, so like they make some, but I guess it just disappears quickly because it's not
So
going to do
take
anything.
the liver and look at the messenger RNA behind IGF-1 messenger RNA levels.
Maybe I'm would have to look at it. But yeah, I don't know. I'm not sure. Okay. Yes, let's see. You mentioned the late puberty. Have these mutations helped understand the connection between growth and GnRH production? This is from Dr. Winters. Not that I know. And I think, you know, I think the cases of the late puberty, like, yes, have been in few of the patients with the Laron syndrome, and I think some of the patients with ALS. But in general, all of them like will eventually go through puberty. So I don't think that we understand very well that connection. And here there's another one. Where is the genetic testing done? And is the DNA isolated from saliva or lymphocytes? I think you can actually isolate the DNA from saliva, yes, or you can isolate it from the blood. So I think you can easily do just a saliva test or a blood sample. And I think a lot of the commercial labs will just sequence like a particular gene. They also have like sets of genes. So if you have someone with IGF-1 receptor, like IGF-1 resistance, you can potentially just test, you know, a group of genes. Or so I think that testing is relatively easy to get. It's a little harder to get approved by insurance, though. So I think that's the more complicated part. And I think that's all I have. All righty. Well, thank you, everybody.